Yes, sir.
Now, the next is about multiple myeloma. Multiple myeloma is again a issue of whether it's to be considered as a orthopedic discipline or whether it is the hematological. There is a sort of confusion, but in general, it's considered as a disease related to the hematological system because it affects the bone marrow mainly. Now it's defined as it's a plasma cell malignancy in which monoclonal plasma cells proliferate in the bone marrow, resulting in the overabundance of monoclonal paraprotein that it's also called as a M protein. Of course, this definition is a somewhat recent definition where the existence of a specific monoclonal paraprotein is identified. Whereas earlier it was defined as Bence-Jones protein, which is present in the urine. Now, in the present day situation, Bence-Jones protein is not very specific of the multiple myeloma. It may be present in many other conditions, and the actual this sensitivity of the Bence-Jones protein also is considerably low, whereas the paraprotein M protein is now considered to be the benchmark for the diagnosis, and the method of identification is electrophoresis, which results in the destruction of the bone and displacement of other hematopoietic cells as such. Now, in general, it's determined as that monoclonal gammopathy, that the changes in the protein synthesis of the body, particularly the gamma protein, is considered to be one of the initial stages which it starts with the mutation of the cells, and this results in a situation where the cells cannot proliferate or capacity of the cells to proliferate would be affected, and these plasma cells are usually take less than 10% of the bone marrow, and the serum protein level tends to be reduced. The serum albumin level tends to be reduced due to this presence of the gamma protein, and it also can result in further progression into the next stage where the other tissues are involved, other organs are involved, and this process is a relatively slow process, and hence the stages of myeloma are considered as initially the stage where there is only the protein changes but there are no involvement as such. Then there is a smoldering phase where there is a gradual progression where the protein level tends to be at the range of 3 grams per dl, and further on as the number of these malignant cells increases, that results in the established multiple myeloma. So multiple myeloma now is considered in 3 stages: the monoclonal gammopathy of undetermined significance, that's MGS, and it is considered that about 1% of the people will per year will go on to develop myeloma. Almost 99% of the people who have monoclonal gammopathy, that's the abnormality of the gamma protein may be present in the body, and assess the M protein level, it may be abnormal, but they may not develop a myeloma, but gradually at least about 1% of the people may develop into myeloma, whereas 10% of the people they develop into a smoldering multiple myeloma where the risk of progression would be slower. So when you see a patient of myeloma, you may see the patients in any of these stages. Rather, majority of the people would be in the first or second category, that's a monoclonal gammopathy, or it could be the smoldering myeloma. The real established multiple myeloma would be seen in a lesser number of people. That makes the issue a bit more complicated, or rather somewhat complicated, or maybe from the treatment point of view also that produces certain issues. Now again, the same, what I mean by these 3 stages is in the normal conditions there would be plasma B cells which will produce immunoglobulin, the normal immunoglobulin. In the MGS condition, monoclonal gamma neuropathy, the immunoglobulin secreted by the bone marrow is abnormal, which would be resulting in what we call as M protein, which would have a concentration of maybe less than 3 grams per dl in the initial stages. That's what we call as MGS. And bone marrow cell infiltration would be less than 10%, and there are no other involvement of the other organs, and in these stages the patient may have increased risk of fractures and changes in the bone very density only. Initial stages in the bone only are seen, no other organ is involved in the MGS state. Further, when it results in the smoldering myeloma, it gradually progresses, and when it becomes established in multiple myeloma, it's defined that multiple myeloma is defined now as a serum monoclonal protein of more than 3 grams per dl, and bone marrow plasma cell infiltration more than 10%, and there is a involvement of other organs, end organ damage, either kidneys or maybe the liver also may be involved, and spinal cord may get compressed. Very often we see the patients of myeloma after they get the compression of the bone marrow or spinal cord, and increased risk of fractures of course would be there, and that produces the issues. Incidence of multiple myeloma globally is it's more in the Asian area, particularly India and this Russia area, whereas comparatively it is lower in the Western countries. The global case count as per the data is around 1,60,000 new cases per year, and the age under incident ratio is around 5.5 per 1 lakh people, and highest incidence is Australia, New Zealand, North America and Northern Europe. Lowest incidence is Western Africa and Melanesia, that's in this western part of the Asian country. And median age at the diagnosis is around 69 years, and less than 14% of the patients are younger than 55 years. So in general, majority of the patients are of the relatively old age, and only 3% are younger than 45 years. The clinical presentation, as in case of the, as we have discussed about the pathological stages like the MGS, gamma this protein or the multiple smoldering myeloma and the multiple myeloma. The pathophysiological basis of clinical sequence also are categorized into the skeletal. So initially it's in the skeletal where the bone and bone marrow are involved. Then results in hematologic, it involves the blood, the peripheral blood picture and the blood involvement. Renal and nervous system also may be increased or affected in course of time. So clinical presentation of the multiple myeloma are studied under skeletal phase, hematologic phase, renal phase and nervous system phase. And then of course there are certain general processes which involve the blood picture, or there could be symptoms produced that. In the skeletal process, because of the plasma cell infiltration, it results in the skeletal bone destruction, osteolytic lesions, anemia and the hypercalcemia. Serum calcium level would be raised. The hematological process, because of the involvement of the bone marrow and the plasma cells as such, there will be neutropenia. The total WBC count may be lesser, patient tends to be anemic, and even there could be thrombocytopenia. Platelet count could be reduced. The renal process would be, there would be a renal injury due to the, in the tubuli due to deposition of the amyloid substance, amyloidosis, or involvement of the plasma as such, the plasmacytes as such, and that may be resulting in nephropathy or hyperuricemia. That different sorts of the diseases of the kidney, and the uric acid level also tends to be raised, and the renal infiltration of the plasma cells also can result in the light chain nephropathy or amyloidosis, where the kidney may have deposition of the amyloid substance. Of course, the amyloid substance would be deposited in other organs of the body like tongue also, and that results in the sclerosis of the glomerulus. Neurological process may be involved where the nerves, roots, radicals of the spinal nerves, either they may get compressed due to the skeletal destruction, or it also could be due to the amyloid infiltration of the nerves. And the other processes which could be presented are hyperviscosity syndrome, because of the increased density or viscosity of the blood. The ratio between the cells and the fluid of the blood would be enhanced, and that results in the purpura, retinal hemorrhages, edema in the papilla, coronary ischemia, and central nervous systems like confusion, vertigo, seizures, etc. also can occur. And the Raynaud phenomena like presentation where there would be peripheral gangrene also can occur in the multiple myeloma. The range of symptoms, a good number of patients would be asymptomatic, and it may even result in very severe symptomatic treatment with complications, severe complications also. The range of clinical symptoms could be quite wide. A good number of patients will be totally asymptomatic. Only when the blood is there is investigations done, you may find this. Or maximum patient would have only bone pain, vague bone pain. The difference between a bone pain produced due to the myeloma and the others are other bone pathology like degenerative diseases are. Usually the degenerative diseases, the pain will be in the epiphysic end, epiphysis of the bone near the joints. Whereas in multiple myeloma, it's in the diaphysis of the bone, and vertebral bodies would be commonly involved, as well as long bones also involved. Long bones like femur and tibia also are involved, where the patient would have pain in the shaft of the bone, and the pain would be more in the resting hours than really in the during the active phase. Now, unlike that of the degenerative pathologies, the patient would have more pain when the patient is more movable or when there is more load on the bone, whereas the patients of myeloma would have somewhat better situation in the erect posture or when there is a load. Or many of the conditions of myeloma could be diagnosed only when the patient has a pathological fracture. It could occur in any of the bone, but again incidence is more common in the spinal vertebral bodies, resulting in spinal cord compression as a result of pathological fracture. Then other clinical symptoms like weakness, malaise, bleeding, anemia. Patient may have a repeated infection because of the effective involvement of the immunoglobulin pectins. Hypercalcemia, the calcium level would be raised. As a result of that raised calcium level, patient may have incidence of the stones, kidneys in the stones in the kidney, or even coronary pathologies. Hypercalcemia and kidney failure also could occur. The neuropathies, different sorts of neurological diseases also can occur. Almost 1/3 of the patients, the condition is diagnosed after a pathological fracture occurs, usually involving the axial skeleton, that's the vertebral column. Bone pain, as such, the more description of the symptoms. The most cases, that's around 70% of the patients have bone pain in the beginning condition. Lumbar spine is one of the most common site of the pain. Pathological fractures, they occur almost in 93% of the patients, and they may have more than one site of the bone involvement. A severe bone pathological fracture also can be a presenting symptom as such. Spinal cord compression has to be considered. Any patient complaining of back pain, weakness, numbness, or abnormal sensations in the extremities. Because of the spinal cord compression, multiple myeloma may occur at multiple levels, and usually it may occur at both cervical as well as lumbar area, and a thorough evaluation of a patient with low back ache is necessary. Patients who are moving about at the start of the therapy may have a better clinical presentation, avoiding that paralysis as such. Bleeding, occasionally a patient may have a symptom of bleeding due to thrombocytopenia, and rarely a bleeding which has occurred and which has stopped due to the clot may get again recurrence of bleeding due to the dissolution of the clot by the M protein. That's very typical, like a patient who had some other episode of bleeding, the bleeding had stopped, but after around 24 hours or 48 hours, the clot gets dissolved, and hence there is a recurrence of bleeding. That secondary bleeding tends to occur, and that also is somewhat characteristic. Increase in the calcium level results in confusion, somnolence, that's moving in the night or during sleep, bone pain, constipation, nausea, or thirst are the other presenting symptoms. Complication may be presented in almost 30% of the patients with the presentations as such. And that's infections, they tend to occur due to abnormal humoral immunity of leukopenia as well as the abnormal immunoglobulin level. Pneumococcal organisms are more frequently involved. Herpes is another of the presentation in many of the patients. It's also common as. Or Haemophilus infections also could be seen there. Increased viscosity may be associated with the number of symptoms like malaise, infection, fever, paresthesia, sluggish mentation, that's thought process being affected. Sensory losses, patients may have headache or somnolence, and they may even bruise early easily, that there could be hemorrhagic spots, or vision may be hazy, and this would be accompanied with the increased serum viscosity, which is almost 4 times more than the normal. Epistaxis also may occur as a symptom in patients who have a high tumor volume, that where the total number of mutated cells are high. Occasionally patients may have high mononuclear protein in their blood, and that itself results in increase in the viscosity, and it also can present with the stroke, myocardial ischemia, or infarction. Neurological symptoms like carpal tunnel syndrome also is a complication of myeloma. Meningitis also could be presented in multiple myeloma, and peripheral neuropathies also could be related to multiple myeloma. Anemia, which is maybe quite severe, is the most common cause of weakness in patients as such. Certain typical clinical signs which could be presented in advanced stages of myeloma are due to that deposition of the amyloid over the muscles. There could be that shoulder pad sign, the shoulder tends to get bulged, or there could be due to deposition of amyloid substance over the other area, particularly over the tongue. You may see that myeloid cells, macroglossia, the total tongue may become bigger in size. Or the other rashes could be skin rashes, could be presented as one of the common clinical presentation of multiple myeloma, and the almost only less than 1% of the people may have involvement of their skin, and the skin rashes, when they occur, they are very typical, like there will be raised papular eruptions which are limited to certain zone of the area, and there will be no discharge, no scaling, or later it may become an ulcerated lesion with the necrosis, or it could be simply a petechia, large number of petechia. Any of these could be the consequence of the myeloma, skin presentations. Renal failure or renal insufficiency is seen in 25% of the patients, and may be due to the either myeloma kidney syndrome, deposition of the amyloid deposition in the kidney, or nephrocalcinosis due to hypercalcemia. So once a patient has impaired renal functions, you will have to investigate like whether it's due to the deposition or due to increased calcium level, or it's simply the multiple myeloma complications. The guidelines for the investigations would be, now the International Myeloma Workshop guidelines has given some guidelines to make the diagnosis and to investigations also in suspected case of multiple myeloma. The first is serum and urine assessment of monoclonal protein with the densitometer treating, or with the immunofixation, the immunoelectrophoresis, or free light chain assay. Now earlier the criteria was Benz-Jones protein, as I told you. These days Benz-Jones protein is considered to be less sensitive, and the priority is for the immunoelectrophoresis. But immunoelectrophoresis is a relatively costly process, and the technology also is involving some complicated issues, complex issues. Blood sample has to be taken fresh, and immediately it has to be done. So when you refer a patient for immunoelectrophoresis from our setup, like hospital where we do not have a setup directly, it may not be possible. The patient has to be in the laboratory as a walk-in patient, and in the laboratory the blood has to be collected, and within a short duration the blood has to be processed, and hence the access to that investigation may not be available in all hospitals. Only in certain hospitals where they have that kind of infrastructure, it may be possible to have the investigations of the monoclonal protein or M protein, whereas Benz-Jones protein, it can be assessed anywhere. The other investigations which are recommended are bone marrow aspiration or biopsy, or serum beta 2 microglobulin, albumin and lactate hydrogenase measurement, or cytogenetics, where the cell's genetics, again very advanced method of investigation, or fluorescence in situ, or skeletal survey, or MRI. Something which we can use are the skeletal survey and MRI. Skeletal survey, ideally, it involves a lateral radiograph of the skull, anterior, posterior and lateral views of the spine, and AP views of humerus, ribs, pelvis and femoral. Inclusion of at least 3 these bones is important for diagnosis as well as staging. The other imaging studies are simple radiography of revolution of skeletal cells, which is quite common, and the MRI for detecting thoracic and lumbar spine lesions, for paraspinal enlargement, PET scanning for potentially useful conditions. The plain X-ray, now I will be giving somewhat more detail about the plain X-ray. The plain X-ray findings could be of different categories. The lytic lesions, I will show some examples also, where there will be well circumscribed round lesions which look like punched out appearances in the bone. They are usually seen in very advanced stages of myeloma. Endosteal scalloping are in long bones, where the endosteum, that's the tissue in the bone, the medulla of the bone area, would be somewhat rough, and there will be multiple layer-like appearances. That also is suggestive of advanced stages. Diffuse osteoporosis, they also occur somewhat in the middle stage, in the smoldering conditions, where there will be widespread osteoporosis, and usually again they are seen in the spine. I will show some examples of these X-rays also. Salt and pepper pattern is usually suggestive of mild disease, where there will be roughness in the diplo of the skull bone, or the whole area becomes somewhat rough as such, or minimal infiltration at the early stages of infiltration as such. Sensitivity of plain X-ray is around 35 to 50%. CT is around, again almost same, 37 to 50%. MRI 68 to 93%. PET scan nearly 100%. Now what we mean by these lesions are the lytic lesions, where you will see punched out appearances, like where there will be multiple hole-like appearances, if that is a bullet hit area, and very commonly seen in the flat bones, and we usually give a lot of priority to the skull bone in making the diagnosis, and there again lateral view of the skull is preferred. Pelvic bones also, the other bones which are affected quite frequently with this kind of punched out appearance lesions, suggestive of the multiple myeloma, which is confirmatory and seen in very advanced stages. Endosteal scalloping, again another of the advanced stage sign, would be in the endosteum. You will see the multiple layers, the periosteum, endosteum. In the endosteum there will be somewhat roughness, and there will be one dense layer, then a less dense layer. That kind of an appearance is seen, which also can lead to a pathological fracture, as you see in the second image, and these also are very characteristic of the plain X-ray. Osteoporosis, widespread osteoporosis involving multiple bones, which could be made out in the X-rays, where there will be increased density and somewhat periosteal erosion in some areas, also are characteristic. If you remember, just a few weeks back we had a patient from somewhere Bihar who was admitted in 134. He had almost a similar issue. Of course his Benson's protein test was negative, but still we have continued to make the diagnosis of multiple myeloma, and probably he is in the smoldering stage. MRI CT scan give you that better idea of this osteoporosis, diffuse osteoporosis with either mild changes in the morphology of the vertebral body or severe changes in the morphology of the vertebral bodies. And once we, depending upon the intensity of changes in the vertebral bodies, the clinical symptoms of nerve involvement, either there could be a spinal cord compression or a nerve root compression, and hence the patient may present with symptoms of backache. Or even it can result, that diffuse osteoporosis also can result in a pathological fracture, gross pathological fracture, and there could be a total spinal canal stenosis that also can occur in such conditions. Then what we call as a salt and pepper image is again suggestive of a relatively early phase, where there would be FSR deposition of the calcium. Somewhere there will be erosion of the bone, somewhere there will be a less higher density, and when you look at the scalp X-ray, you will find as if there are something like crystals deposited over there, spread over, and this is called as salt and pepper image. A CT scan give you that salt and pepper image, that's some dark spots and white spots, salt, white spots, pepper, dark spots, and minimal infiltration are also called as occult changes, very early changes in the osteoporosis, which again is quite difficult. Most of the times, majority of the patients may be seen at this stage, and they, at that stage it will be quite difficult to differentiate it from any other cause of osteoporosis. Only when you go for the serological study you may make out. So a good number of patients may not be diagnosed at that stage, but when there are certain other clues, these also can be helpful in making the diagnosis. PET scan gives you more accurate issues. Either there could be abnormal deposition of the scan, or there could be widening of the bone. The scapula has become widened in this case, or there could be involvement of the lymphatic system also, lymph nodes also could be involved. The monogammopathy, identification of the M protein gamma is done by immunoelectrophoresis. So if you refer a patient for the immunoelectrophoresis, you will get the graph. The normal graph would be the albumin would be high and the gamma globulin would be lesser, where the alpha, beta and gamma proteins are spread in the electrophoresis strip acid, whereas in monoclonal gammopathy, that gamma extent would be higher than that of the albumin level, and this is how you see make out as such. But Benston's protein is though it's considered as a old method of investigation, still it is used because it is very easy to make out the diagnosis. The process is very simple, and it was described in 1845 for the first time, and it has its own relevance now also, though it's not very specific of myeloma. The Benston's protein is method of assessing is as simple as that of urine albumin level. So in the you collect the urine and maybe concentrated the urine and heat the urine with the acidification, adding acetic acid. In case of the issues related to the albumin, there will be a cloudiness as you heat it up, boil it, and till it reaches boiling temperature there would be a precipitation, and the precipitation remains as such even though it is cooled down. Whereas in case of the Benston's protein, the protein is presented in between 60 to 90 degrees centigrade, and when it reaches to 100 degrees centigrade, cloudiness completely disappears, and as it gets cooled down, again the cloudiness is seen, and this is a qualitative test for the Benston's protein, which is relatively easy to make out, and hence it still has some relevance in setup like our setup. Anyway, that's about one thing. The staging of myeloma is done under different disciplines. One of the staging system is called as Salmon-Dewey staging system, and it depends upon the multiple myeloma cell mass in the bone marrow. So only after you study the bone marrow, and if the bone marrow abnormal cells, myeloma cells are less than 0.6 into 10 to the power 12 cells per square meter, then a patient's hemoglobin value is more than 10 grams, serum calcium value is less than 12 milligram, normal bone structure or low M component rates, then it's considered as the stage 1, or the other way, the revised stages would be, staging is based upon these issues, the levels of hemoglobin, calcium value, etc. In the revised international staging system, which is now considered as a standard, you need to have the FISH test or fluorescence in situ hybridization test of the tissue, again which is also a bit costly. Now that FISH test now costs around 15,000 for one test asset after the bone marrow, so the whole process becomes costly. And stage 1 is considered where the chromosomal abnormalities are lesser, and stage 2 when it's in between stage 3 and stage 2. In stage 3 there will be high chromosomal involvement of the chromosome seen as such. Treatment protocol is mainly chemotherapy is suggested as a treatment, and used chemotherapy drugs are thalidomide, lenalidomide and bortezomib. But if the patient is in the early stages like smoldering or early stages, there is no need of treatment as such. It's better that the patient can be managed with symptomatic drugs. We have good number of patients who are somewhere in that intermediate stage where chemotherapy is not advised, and we manage with our own drugs like usually gugulus, depending upon the clinical symptoms, gugulu, ekagvir, etc. And the patient can be put on for years together without reaching to the stage of myeloma and multiple myeloma. Transplantation, bone marrow transplantation is considered, autologous transplantation is now considered as one of the means where the peripheral, bone marrow or patient's own bone marrow cells are transferred after a chemotherapy, this redundant chemotherapy. Active chemotherapy is done after keeping the stem cells of the patient in a culture, and after that lethal doses of radiation or chemotherapy, again the same is infused into the bone marrow, and this is a technique which has now becoming popular and claimed to be very potent method of treating multiple myeloma. But the whole issue is again a complex issue. Very few centers in India have that kind of a facility. Another is the T-cell therapy or chimeric antigen receptor T-cell therapy, which is approved very recently in 2024, which is considered to be the latest. Advantages and disadvantages are not known much. It's only from the academic point of view for us, like because it was identified only in April 2024, recognized in 2024. Radiation therapy is to stabilize the fractures, particularly those who have a bone involvement. There are certain reports which claim that multiple myeloma can be prevented by ultraviolet irradiation. This is again somewhat in the early stages. Survival ranging from 1 year to more than 10 years, and median survival in unselected patients is around 3 years. 5-year relative survival rate is around 46.6%. Prediction of the prognosis would be by C-reactive protein, CRP, and beta macroglobulin. If it is high, if the levels of both proteins are more than 6 mg, the median survival period is around 54 months. If the level of only one component is less than 6 mg per ml, then median survival is around 27 months. If level of both protein values are greater than 6 mg, then median survival is 6 months. The poor prognosis also is related to tumor mass, hypercalcemia, Benz-Jones proteinemia, kidney impairment. This is about the general issue of myeloma. Last part in the hematological disorder, not so common, not so important, but still somewhat significant, would be lymphoproliferative disorders. Lymphoproliferative disorders are a group of disorders where there will be an abnormal proliferation of lymphatic sites, and it is again could be of two categories. One where it's endogenous, due to some reasons the lymph nodes develop. But post-transplantation, these days as the transplantation is a common event, after the transplantation incidence of lymphoproliferative disorders are increasing, and the number of patients with the lymphoproliferative disorders also are increasing. So physiological form of lymphocytes, usually once the lymphocytes are, they would be destroyed by lymphocytosis, whereas in the patients of lymphoproliferative disorders, it could be it may continue, and it also is considered to be of three categories. Childhood immunodeficiency syndromes, where approximately 50% of the tumors may have a lymphoid neoplasm, and then the patient may have a lymphoproliferative disorder. Then there are inherited causes like genetic pathology. The identified genetic conditions are autoimmune lymphoproliferative syndromes or ALPS, agammaglobulinemia, immune deficiency, and Cherak-Higashi syndrome. Now these syndromes are not very important issue, but there could be an inheritance, genetic abnormality. The other issue of real concern now is post-transplant lymphoproliferative disorder or PTLD, because the transplantations are now becoming popular. The post-transplant is classified by WHO into early lesions where there could be plasmacytic hyperplasia, and it could be seen in almost in 100% of the patients where there could be Ebola virus. Some virus may be Ebola virus may be present in such patients, and the linkage between the Ebola virus and after the transplantation, that is the issue of concern now. Lots of studies are going on in that direction. Then another category is the polymorphic or monomorphic. Polymorphic is where there could be the cells of multiple patterns, and there the Ebola virus involvement is around 90%. Monomorphic, where the cells are destructive, usually of non-Hodgkin type of cells, the Ebola virus involvement is around 10 to 48%. And Hodgkin lymphoma also may be presented with the lymphoproliferative disorder, where it could be less than 90%. The lymphoproliferative disorder is considered to be the disease of the future, and there is, as per the analysis, the future market size will be increasing rapidly, and the drugs which are now becoming popular, new drugs which are coming up, would be birmositin, doxorubicin, and so on, which are, and certain of the drugs which are in the pipeline. Of course, from the current existing our clinical point of view, we may not have much opportunity to treat the patient of lymphoproliferative disorder, but this is considered to be disease of the future, and hence somewhat detail is necessary. Clinical presentation, mainly there would be swollen lymph nodes and swollen liver or spleen. Patient may have bone pain, fatigue, weakness, weight loss, night sweats, frequent infections, typical as any other lymphoid disorder. So a patient presenting with a lymph node enlargement, usually when you make the diagnosis of lymphomas, one of the other conditions which has to be now kept in mind would be lymphoproliferative disorder, particularly if the patient is having a history of transplantation, or if the patient is a very young child. This needs to be, and the diagnosis is essentially based upon the histopathological evidences. Only when you send the biopsy, lymph node for the biopsy, you may get that impression. The confirmation can also be done by radiological investigations, where the angiogram shows the typical signs of a lymphoma, primary lymphoma. Or in the plain X-ray also you may see that density, increased density, opacity seen with that hollow area, and that is one of the radiological evidences. Medications, again, there could be either immunoglobulin therapy, steroids, cyclosin. These are all the different sorts of the treatment tried. Again, I will not go into the detail of each of these. Chemotherapy drugs, radiation therapy, or stem cell transplantation, targeted therapy or antiviral therapy, all of them, they are in the different stages of either trial or maybe in the initial stages of the management. The data available about these also is comparatively lesser because it is somewhat a new disease. Prognosis also depends upon the type of the proliferative disorder, patient's age, and other factors. In total, about the leukemia, so this is the last part. Now we will conclude about the hematological neoplasms. Now the outlook about the leukemia has changed vastly. Lot of information is altered in the last 150 years, from 1845 to 2001. The changes are enormous. The concept about the knowledge of leukemia in general, now I am not only talking about this, every year, almost every 5 or 10 years span, there is a significant change in the outlook, significant change in the investigative process and the treatment, as well as the prognostic issues. And hence, whenever we deal with the leukemias, we need to be very up to date. With this, we will conclude today's session, and next we will discuss about genital area tumors of the genital organs. Right? Okay. If there are any questions, otherwise we will wind up. Right.
Thank